I'm delighted to welcome along Professor Helen Payne, who holds a PhD from the University of London and who's based at the University of Hertfordshire, where she supervises a number of PhD students and teaches in doctoral and master's programs as well as continuing professional education. Since 1990, she's been accredited as a United Kingdom Council for Psychotherapy psychotherapist and a fellow of and senior registered dance movement psychotherapist with the Association for Dance Movement Psychotherapy. She's a fellow of the Higher Education Academy, supervises and examines doctoral candidates internationally. Beginning as a specialist physical educationalist in secondary and special schools and hospitals, for 3 decades she has pioneered the development of embodied dynamic psychotherapy, specifically DMP, starting the professional association, first training, research and publications. Early practice-based research was with children and adolescents with special educational needs, particularly those with communication disorders such as ASD. Recent research has been concerned with personal development groups for postgraduate trainees in the psychological therapies and embodied practice with patients with medically unexplained symptoms in primary care, which she's going to be talking to us about this evening, I think. She has a number of publications, including Creative Movement and Dance in Group Work, a handbook of inquiring the arts therapies, DMP Theory, Research and Practice, Volumes 1 and 2, and DMP Supervision. She has managed funded and non-funded research projects using mixed and qualitative methodologies. She's founding editor-in-chief for the international peer-reviewed journal Body, Movement and Dance in Psychotherapy, published by Taylor and Francis. Her clinical work with adults, children and adolescents with autism, learning disabilities, behavioural problems and offenders has influenced her approach to DMP, also informed by her extensive research. She has a private practice with groups and individuals. More recently, she has founded a university spin-out company at Hertfordshire on Pathways to Wellbeing Limited, transferring research into business to develop a specific treatment approach called the body-mind approach in the NHS for patients with medically unexplained symptoms. Helen.
Thank you very much. Thank you for that very comprehensive introduction. Have I really done all that? Gosh, sounds a lot. Well, I'm delighted to be here. Thank you so much for inviting me, Vicky Kaku, Professor here, to be part of the Arts in Wellbeing public lectures series. I'm really honoured to be part of this. I'm going to talk to you about these particular symptoms, the hard to control medically unexplained symptoms, and we're going to look a little bit about well-being and how well-being in body and mind can help support patients, people with these symptoms. And I've got the jigsaw there because these symptoms are so difficult to put into a box, if you like. They don't fit anywhere. So difficult to diagnose, therefore difficult to treat. So anyway, we'll go into that in a little bit more depth in a minute. So what I'm going to talk about today is these symptoms, the prevalence of them, the costs, what are they, and what is the treatment, and do you have them? Do we know what they are? Looking at the definition of terms, because there are a lot of terms around these symptoms, and how does it actually feel to have one or more of these symptoms? We'll look at what well-being is, and we'll look at the body-mind approach specifically and how that can promote well-being. And then we'll look at the spin-out company that was mentioned, Pathways to Wellbeing, and the courses that we offer and how that promotes well-being in body and mind. We're going to have a break for our bodies and mind, a little bit of a time to stop and breathe a little bit. And then I'm going to look at I'm going to explain to you the barriers that we faced when we began this business in the NHS and the difficulties we had in actually implementing the service, and then how we overcame the barriers. What were the drivers and what were the lessons learned, and looking at the transferability. And finally, I hope to have some time at the end for questions. So patients come with pain often, headache. They're frustrated, they don't know what to do. The GP doesn't know what to do. The medical specialists don't know what to do. So everybody is frustrated about where do we go with this symptom? How do we help this patient? Medically hard to explain symptoms. So, as I said before, they don't fit into a known diagnosis. But how common are they? In primary care, you'd be surprised to know between 15 and 25%, that's the range of studies that have been done, for every consultation. So you're looking at a GP list, and between 15 and 25% of that GP list, those patients will have medically unexplained symptoms. In the outpatients in the hospitals, you're looking at much greater numbers, 35 to 52%, depending on what medical specialism. So mainly in neurology, gastroenterology, rheumatology, cardiology, and a lot in women, particularly in gynecology. So the pain comes from headaches, as we've said, many back pain, unexplained, and people go through even surgery, and it doesn't go away. So it can be quite iterative and quite damaging, actually, for patients. Dizziness is another one. They have no explanation for it. It's not to do with balance. It's not to do with the inner ear, for example. But there's no medical explanation, but patients do complain of it. So it's a major problem, very common, called a long-term condition. So like diabetes, heart disease and so on, cancer, medically unexplained symptoms is in that category of long-term conditions. And it's associated with very high costs indeed. The problem is not well managed currently in the health service. And in addition to the patients having these bodily symptoms, they suffer either as a result of the bodily symptoms or the bodily symptoms as a result of anxiety and depression. So they have a mental health issue as well. And also these symptoms can be associated with unexplained medical illness. So let's look at the costs. So in the NHS, the most costly diagnostic category is MUS, and in 2008 it was 3 billion. And that raises up to 18 billion if you look at absence from work and poor quality of life and so on, because there's a lot of productivity lost through these symptoms. It's the fourth most expensive category in primary care. In the Netherlands, it's the fifth most expensive category. In the USA, it's also the fifth most frequent reason for a clinic visit, costing about 60 million a year. So it's a worldwide problem. But there's also this other hidden cost that we don't really recognise. It's to the patient. Every time they go for an appointment, it costs them. It costs them financially, but it also costs them emotionally. They have to wait around in a waiting room for a long time. They have to pay for car parks that cost a lot of money. They're always going for tests and scans and so on, lots of investigations at hospitals. So it's very expensive for the patient too. So what kind of symptoms? Often it's pain, but not always. IBS is very common indeed, irritable bowel syndrome. Chronic fatigue is also very common, where people feel they don't have any energy at all. They can't even get out of bed. Or if they do, they're very stiff and they can't really get going in the morning. So they're tired all the time. ME comes into this category: back pain, chest pain, headaches, as we've said, breathing problems, so catching your breath and then not being able to breathe out, for example, or breathing very, very quickly just in the top part of your lungs. Various skin conditions, musculoskeletal pain and palpitations, insomnia, and many more. There's as many symptoms as there are people, actually. There's so many different symptoms, you can just make them all up. But these are hard to explain. Patients really feel the sensations. They really have these symptoms. It's not all in their head, as people used to think. It's not psychosomatic. So, if you've got these symptoms, does your GP send you for appointments? Do you go to your local hospital for tests and scans, and they all come back negative? Is it difficult to get this diagnosis? Do you sometimes feel overwhelmed with the symptoms so that they just become the main thing you're concerned with and preoccupation in your life? And do they stress you out? Often patients will say, these symptoms really stress me out and they make me feel very low. And if you're tired all the time or in pain all the time, it's very debilitating. So it's natural people will have anxiety and depression accompanying them. And does your GP not seem to know what the problem is? They sort of commonly say, GPs commonly say, I've heard patients say, they commonly say, oh, you just have to learn to live with it. Just go away, you have to learn to live with it. Nothing we can do. I mean, that is, that is the treatment, but it's not a treatment. It doesn't help patients. And if you've had if you had the symptoms for over 6 months, then it's chronic. And that's when we would take that patient into one of our courses. So that's one of the inclusion criteria. So what kind of definition might we use? This is one of them. It can't be fully explained, this symptom. It can't be explained by any known medical condition. That's not to say there isn't a medical condition. We don't know everything in medicine. Medics aren't gods. They don't know everything. It might be an unknown medical condition that just hasn't yet been identified. But it's still termed a medically unexplained symptom. Lots of terms associated with medically unexplained symptoms. For example, hypochondriasis, which is about a lot of anxiety around symptoms, or just feeling general anxiety around health issues. So, for example, if you were born into a family where a significant other or a sibling was constantly ill or had a very terminal disease or something, then you might pick up that anxiety and become yourself quite anxious about your own health, for example. Somatization, that's a disorder where there's a high number of symptoms, 4+ symptoms, so symptoms all over the body, and repeating, coming back. One goes away, another one comes. That one goes away, another one comes. And functional somatic syndromes like IBS, chronic fatigue, and fibromyalgia. Other terms have been used like undifferentiated somatoform disorder, usually in psychiatry. Somatization disorder, again, usually known in psychiatry. The DSM is the diagnostic manual, which is now coming up to number 5. So there's going to be a new manual. Pain disorder is another one, and they're going to probably call it, we're not sure yet, but they're probably going to call it bodily distress disorder. That's one that they've done quite a lot of research on with focus groups, with patients and GPs. They seem to like it, but they've got to do a much bigger study with thousands and thousands and thousands all over the world in order to make sure that is the correct term. Because patients don't really like MUS, and nor do GPs. And it was put in there in DSM-4, but they're thinking to change it, and probably that's the one they're going to use. So that's the posture. Feeling hopeless, really. Nothing can be done. I'm stuck with these symptoms. Nothing can be done. How might it feel to have these symptoms? Well, as I say, pain, chronic pain, day in, day out, week in, week out, month in, year in, is very debilitating. It gets people down. They can't go to work. They can't socialise. Sometimes they can't even drive the car. Sometimes they can't even go upstairs to bed. They feel all alone with their symptoms, with little hope. They feel unsupported by their GP and their family and friends often too. Family and friends get frustrated, and then they get fed up with hearing the complaints over and over. So they feel isolated. They get fed up that the tests keep coming back negative. They feel stressed that nothing has been found yet. They feel completely dispirited that they'll ever feel any better. And then they ask themselves, am I the only person that the GP can't find a diagnosis for? They think they're the only one. And of course, if you are on medication, you'll ask anyone who's on medication, they prefer not to be. But they can't actually not be on medication because it does help with the pain, if it's pain, for example. So they feel a bit trapped. So what would people with these symptoms like to be able to feel or do? They would like to feel more understood. They would like to feel supported. They would like to feel that they can live well, despite the symptoms, in body and mind. They would like to feel less stressed and feel more in control, because the symptoms take over in a way and they feel out of control, and that raises their anxiety level or makes them even more depressed. They'd like to feel amongst friendly faces, so that's the way to feel supported. To be able to cut down or stop their medication, to be more active, to be able to do more things, to have a higher level of functioning in everyday life, and to manage their symptoms themselves. And as a result of that, to be able to feel well in body and mind, to improve their well-being overall. So what is well-being? You've had a series of lectures. You should be able to answer this question. So just take 10 minutes to have a little chat with your neighbour to come up with some suggestions of what you think well-being is. And I shall be testing you afterwards. So take a little time, 10 minutes, have a little chat. Okay, so just bring that to a close. Anybody got any ideas? Just one word will do. Just shout them out.
Happiness.
Happiness. Wow, yes. That's overarching. Thank you. Come in. Anyone else? Healthy, yes. Fairness. Pardon? Comfort. Shout it out, please. Quality of life, yes. Anybody else? Any ideas?
We are we just are in control and functioning.
In control and functioning, absolutely. They're all really good ideas, and they are encompassed in the definition I'm going to give you. So it is a subjective feeling, well-being. So your well-being will be different from my experience of well-being. It's subjective, it's a personal feeling. It's a state of being. So not necessarily about doing, it's more a state of being. It is about being comfortable in yourself. Somebody said that. Somebody else said healthy, being comfortable, healthy. And somebody else said happiness, didn't they? And it means that people have, for example, a sense of individual vitality. The dynamism that's inside of us, the vitality, that we can connect with that and we can use that and channel it. It's about undertaking activities which are meaningful for us, engaging for us, that help us to feel competent and autonomous. And it's about having the inner resources or resilience to be able to cope with things when they're not going so well, so that we can bounce back. So changes that are outside of our control, we can bounce back after that. Yes, we can feel perhaps a bit low while we're going through those, but we bounce back afterwards. That's what resilience is. And many of our patients don't have that inner resilience. And part of what we're trying to do on the courses is to build that inner resilience, so that when the bad days are bad, they're not quite so bad as they were before. And finally, about a sense of relationship. When people are in relationship, in community, and feeling their sense of belonging, in contact with others, socially, they feel more well. So it's about building a sense of community. The degree to which people have supportive relationships and a sense of connection with others promotes well-being. And these are the domains. Obviously, we've got physical, social, the psychological, and also the spiritual. So we're working with the soul as well. Connecting. Very important, because the courses we run are group workshops. So it's working in a group situation. And that is one of the powerful things about this work. So the current treatment for these patients is going to the GP. And they go to the GP week after week after week after week. Probably in excess of 13 to 16 times a year they go to the GP. We're looking at patients who go 6+. They're called frequent flyers because they're going 6 times plus. If you're going less than 6 times a year, you're okay, you're not a fat file. But the frequent flyers are the patients that keep going back because they've never found satisfaction. They keep going back because that's the only place they feel they can go to, or they go to A&E. CBT in psychological therapies has been found to be very beneficial for chronic fatigue and IBS, but it's also been found from the research that it's no better than sophisticated routine GP care for generic MUS, that is. However, The problem with that is that our patients don't want to go to psychological therapies because they've got a pain in their back or a pain in their head or they feel dizzy. So they don't want to go to psychological therapies, mainly because of the stigma that's associated with mental health, which we keep trying to diminish, and the government's been trying to do that. Kevin Jones came out that he was depressed a year or two ago. That, the Liberal Democrats are trying to address this, but it's still stigmatising to go to psychological therapies or therapy. And also the explanation is physical. So if you've got a pain in your back, why would you want to go and work with your mind? Most people don't want to do that. So although the GP might refer them for psychological therapies, they don't go. Or they go once and then they don't go back. So they go for the assessment and then they don't return. So those 6 sessions that were put aside for them are wasted. And what are we trying to do in the NHS? Not have waste, because we haven't got enough money to have all that waste. So we need to conserve. So we need to identify patients who will benefit from psychological therapies and profile those patients rather than just sending people willy-nilly who won't follow it through. So less than 10% of patients receive specific psychological or antidepressant treatment. No action or recommendation in 44% of medical outpatients. That's nearly half. There's no action at all. There's limited patient choice, as I've said, and the best practice treatment pathway in primary or secondary care has yet to be adopted. So we think, in our little company, we think we've got a solution for best practice. We've had feedback from GPs, we've had feedback from medical specialists that this would be best practice. So what is it we do? Pathways to Wellbeing. It's a spin-out company of the University of Hertfordshire based on my own research, and it aims to help people with chronic medically unexplained conditions in primary care, although we are also now exploring secondary care, that is hospitals, and having an MUS clinic in the hospital, so the medical specialist can refer directly to that as an outpatient, to improve well-being in body and mind. And the courses, and I'll go into this a little bit more in depth in a minute, but they have one-to-one consultations, they have group workshops, they have individual monitoring, pre-group, post-group, and follow-up 6 months later. And they have a phase 2 of supportive, non-face-to-face contact, which helps them to embody the action plan that they've designed based on their learning from their group work. They have an action plan which we then nudge them towards embodying over 6 months, so it becomes a habit. So once they've got that habit of their change in whatever it is, lifestyle, diet, whatever they've decided their action plan is to be about, then we nudge them towards sticking to it, because we found that 3 to 5 to 6 months is probably long enough for them to embody that on a day-to-day basis, and then they can do it without the nudges. So first of all, once we've launched the company, we had a Department of Health Quality Improvement Prevention and Productivity Award, and so the Department of Health thought that what we were doing was useful enough to give it an award, and we ran some courses in Hertfordshire, and we've refined our processes based on the research and gathered more practice-based evidence. Since then, we've delivered 5 more courses to date, and we've gained a commission in 2 CCGs, and we've got discussions in other CCGs as well. And the group facilitators are all master's level trained health professionals, and they just need 4 days of top-up CPD to train them to work with these groups of, specifically these groups of patients. So, improving feelings of well-being. How do we do that? Well, in the group work, we construct various practices, various exercises for patients to find this deeper connection with their bodies. Often the body becomes the enemy. Like with any illness, it's about getting rid of something, even so far as cutting things out, actually. One GP told me about a pain, somebody had a pain here, and they, in the end, after about a year of this pain, they said, I just want my gallbladder out. That'll solve everything. So he didn't want to refer her, but he did, and she had the gallbladder out, and then she came back, she still got the pain. So they even go through surgery, which is detrimental, actually, because if you don't need your gallbladder out, why would you go through all that? So it's about being more empowered and taking more control and really aligning ourselves with our body in a positive way in order to feel more that we're more connected and more like an ally as opposed to me and me against you, or an enemy kind of conflict situation. It's about helping patients to listen to bodily signals. So some of these chronic fatigue patients are type A personalities. They have pushed themselves for 10, 20 years through all these difficulties. I remember one patient told me about how she used to do running every single morning. She'd be out there running for hours at a time, and then she'd go to this high pressurized job in her company, and then she'd be running again in the evening as well, and she did that for 10 years, and then she got chronic fatigue. Her body just said, stop, I'm not going to do it anymore. She just collapsed, and she couldn't go to work at all. And now she's had that for 20 years. So some of the signals that we don't take any notice of can actually have an adverse effect. So it's about listening to the bodily signals. If you're tired, then stop, then rest and recover. And listening to the sensory experience in your body, that helps with self-awareness, and give purposeful attention to that. And this can enable comfort. If you're cold, do something about it. A lot of our patients don't. They don't even feel it anymore, or if they're too hot. Learning more about the symptoms in this group setting, which helps to make relationships. So some things come up that are different with other people, and some things come up, that I experience that too, I experience that. So there's some commonalities there. Increasing vitality through movement practices and through breathing particularly. Very, very helpful to do the breathing exercises to help patients really get connected to their breath and their own inner rhythm. That helps with vitality. And other activities using the arts to explore, for example, the meaning of their symptom or the purpose of their symptom. And promoting the inner resources by increasing the coping skills, as I talked about before, to help with resilience by practicing kindness towards the self. The body-mind approach does include mindfulness, and we call it body mindfulness. The term, actually, the body-mind approach came from the research where the patients were asked, what would you call what you did in this course? And they talked about connection between their body and their mind. So that's where the term came from, and that's why it's body, mind in one word, because in English we don't have a term that encompasses the body and the mind together. And it's employing aspects from dance movement psychotherapy, my own background, and mindfulness practices. And mindfulness has been growing in research evidence for depression and anxiety. You don't necessarily need to be a Buddhist to practice meditation. But by practicing some of these mindfulness little exercises, it helps people become more aware of themselves and actually to absorb, if you like, the experience of the symptom as something else that's just passing through. Just like the thought goes in and you watch it go out, and then another one comes. And that's all meditation is. It's not about clearing an empty space, because you're never going to have an empty space. There's no such thing as emptiness. There's always something, but you're just watching it going through you. And that sort of practice helps them to be more accepting and to actually develop more of an inner resource to cope with the symptoms, so that the tolerance level is, they're able to tolerate more of that sensation or less of that sensation than they could before. Market research was done with the GPs to find out whether, when I explained to them what we did, whether this would be something that they would be interested in referring patients to. So we found out about the customer. And then we did a cost-effectiveness study as well, which gave us an idea of whether the intervention would save money in the NHS in primary care. And we found it did save money in primary care, but it saved a hell of a lot more in secondary care, because of course scans at £250 each are expensive. The facilitators deliver in the NHS and privately in their own locality. And we call the group work symptoms groups. And we called it that. First of all, we were calling it learning groups, and then we thought, no, it's not quite right. And somebody said, oh, these groups are all about symptoms. And so we thought, well, we'll call them symptoms groups, because that's what everybody wants to talk about. So they spend the first 2 sessions talking all about their symptoms. So it seemed kind of appropriate to call it that. And for the GPs, we call it the MUS clinic. They have separate brochures, the GP and the patients, to describe what we do. So what's it all about, this exploring through the body-mind? It's about listening and discussing with others. It's about relaxation practices. So we do some visualization, not too many, but we do some progressive relaxation, that sort of thing. The breathing practices I've talked about, making meaning, learning more about the symptoms. When you're learning about your symptoms, you're learning about yourself. We do little hand talks, so there can be a metaphor for the symptom in the way the hand talks about the symptom. And then somebody can witness that, and then they can give a perspective on that the other person hadn't even thought of. And it can actually fit quite well. Sometimes it doesn't, that's fine. But that can be a little practice in dyads, in twos. Discovering inner resources and naming them, and actually writing them down. Everybody has a journal, and everybody is encouraged to write in their journal every session about their understanding or their new learning or coping skills and so on. And naming some of the inner resources they find from some of these practices. Mindfully moving. We just sit in chairs, we're not dancing around the place. We're sitting in chairs and we're just moving mindfully, even very small movements, just fingers. Body awareness is promoted through mindful moving. In fact, the Buddha wrote more about the body in meditation than he wrote about anything else. That was the biggest chapter, so I understand, not that I've read it. Exploring symptoms through the creative arts, like imagery, so always having pens and felt tips and paper around. I also use clay quite a lot, where patients can then model something after the experience, and then that makes it quite concrete. Being curious about the sensation in the symptoms, opening up to new perspectives on their nature, the symptom's nature. So we might, for example, ask a group to think about their symptom as an aspect of nature, whether it be an animal or something in the earth or wind or fire. So just think about the symptom in relation to something in nature. Thinking about the purpose of the symptom in their lives, and then making action plans based on some of this newfound knowing. So it's a group. They're in a group of up to 12 patients. There's hardly ever a time when they're all 12, maybe a couple of sessions, because somebody's always ill, can't get there because they're too tired or too much in pain. But up to 12 patients in a group. Why do we have a group? Well, there's a lot of research evidence to show that learning about your symptom, for example, in a small, nurturing, facilitated, non-judgmental group, helps people feel more in control. They feel supported, but it must be facilitated. And it's with others who have a similar kind of symptom, if you like. It's not necessarily all IBS. It might be some IBS, some fibromyalgia, some dizziness, some headaches, some backaches. It doesn't matter what the symptom is. They've all got symptoms that can't be diagnosed, and that's what brings them together, if you like. That's the common denominator. And this promotes a sense of belonging. People learn from each other about different coping strategies. There's often a lot of sharing in the group about, have you tried this, have you tried that? So there's a lot of common sharing around in that community. And this is just because it's spring. It's about opening up to the world, opening up to their symptom and themselves by doing that. What will you do on the course? Well, nobody can do it wrong, because it's a creative process. It's not about getting it right. No one has to do anything they feel uncomfortable about. The facilitator is very experienced. They've got to have at least five years of working in groups before they can train, post-training. So they will suggest something else if somebody's uncomfortable about doing a particular practice. They're easy exercises, nothing difficult. And it's just about learning how to listen, to find some of that quiet, calm place. Looking at the symptom, its role, how it functions in everyday life, and about ways that we can cope better with our symptom. And that sometimes can be through gentle movement. And sometimes the movement itself is relieving. Rather than holding tight and tense, actually moving through that and relaxing into movement can relieve some of that pain. Using body language, doing body scans, and using the imagination as well to learn more about our bodies. and learning how to nurture and take care of ourselves, because many patients will come and the first thing they do is maybe somebody's got back pain and they might sit in a way that accentuates the back pain. So just thinking about how you're sitting. You know, is that actually going to support your back? What do you need to support your back? Do you need a cushion behind you? Do you need something under your feet? Do you need to sit with two legs evenly, or is it okay to have one crossed? Or maybe it should be the other one crossed. So how do you sit that's most comfortable and most supportive for you? So those sorts of exercises. Taking care of ourselves, really. So what does this pathway to well-being look like? So we've got several steps. We've got the GP makes a referral, as long as there's a contract in that CCG, but we also welcome people to self-book, and then we ask them permission if we can contact their GP to confirm that that is a suitable referral. So they need to give permission for that. Then we send a welcome pack, and we have that communication with the GP. We make a telephone appointment for them to have this pre-group assessment. We have 4 assessment tools. They're all used in IAPT. One is about general overall functioning. One is about the symptom particularly and their well-being. One is about anxiety, and one is about depression, so that we can monitor how they're doing from that first baseline assessment. How have they scored then post-group after having the intervention, and then 6 months down the line, how are they doing now? And depending on how they're doing 6 months down the line, we offer also a self-help group if they're feeling a little bit isolated still and their scores are low. But there's a clinical significance in all of their scores at pre-group, in that they are moderate to severely depressed or anxious when they start, and I'll tell you about the outcomes later, but the reduction in those is quite significant and strikingly positive. So after that appointment, they have now an individual appointment with their group facilitator, where they meet the facilitator for the first time. They can ask any questions. The facilitator will talk them through what happens in the group and give them some boundaries and ground rules about how we work together safely. And then before they get to the group, then once they get to the group, at least they know one person before they start. Because people are quite anxious about joining a strange group. Because groups can be so damaging, actually. And if people have had bad experiences in family, like the first group, or other groups, it can be quite worrying to join a group. So this is a good way to encourage people that it's going to be okay. It's going to be safe. And then they start with the symptoms group. It can either be over 2 weekends, or it can be residential over 5 days, or how we've been doing it in the current CCGs is weekly, over 10 weeks, 1 session a week. The first 2 weeks, they have 2 sessions to embed them for the 4 sessions, and then thereafter there's a weekly, so it sort of tapers off. And then after the group, they have another appointment. They've made their action plan, and then they have a discussion with the facilitator about how they're going to implement that. And there's a contract made about that. They have another telephone monitoring appointment. And then in the last group, they've written this letter, which they write to their future self. So 18 weeks after the group has finished, they imagine themselves there, and they write to themselves with some advice about how to stick to the action plan. And they love getting those letters. We post them to them. They love it because they've written something that in the moment, in that group, based on their learning in that group, and then it rekindles something when they read that letter further down the line. They remember how they felt in the group, how well they felt, and it sort of gives them a bit more of a boost. Then there's a letter also from the facilitator that's sent. I think that's the one, 18 weeks actually, and it's again a little nudge towards supporting them in the action plan, a personalised letter. Then they have a text message to check their email. We ask them how they are, and depending on that comment and their final 6-month monitoring, we discharge them, or we can discharge them and offer them a self-help group if they need it. We haven't had to offer that yet, but if they need it. And that's why we have 12 in a group, because probably maybe 1 or 2 might need it from different groups, and then they can get together. The communication with the GP is all the outcome measures. They get the outcome measures, and they also get the attendance record. So from the evidence so far, we have a participant experience form which all patients complete in the last session in the group, and they've all said they've really, really enjoyed coming to the group, and attendance is fantastic actually. So they benefit from the tests that we've done, the monitoring, increased overall well-being, which is of course what they want, to feel well day to day. They can do more things, so their functioning's improved. Even if it's something very simple like now I can clean out the understairs cupboard, which I haven't been able to do for 10 years. Something like that, because they can bend down now. Increased self-management, which of course is what they also want. They don't want to keep going to the GP, and they don't want to keep going for tests and scans. They want to be able to cope themselves. And most important to the patient, they don't feel the distress of that symptom so much. And in the research, actually lots of symptoms disappeared, but we never promised that. People find that their symptoms do disappear, but that's not what we promise. What we promise is that you will learn ways to live really well with those symptoms. Despite the symptoms, you will learn to live well. They don't feel so depressed, they don't feel so anxious. So we have a 5 to 10% absent rate, which is really exceptional actually for group work. So they are very committed. And also the course is always rated, so far anyway, as excellent or very good. The friends and family test, do you know about that in the GP surgeries? Well, we invented that. We asked them, would you recommend this course to a friend or a family member if they have some symptoms, unexplained symptoms? And they all would recommend it. So that's a good test as to whether they've found it helpful. Let's have a 3-minute break. Have a stretch, stand up. Just stretch your body out a little bit. And standing up, standing up. Just look up to the lights up there. This time breathing in as you reach up and then just breathing out. And if anything needs to be shaken out, shoulders, hips, legs a little bit. Okay. So just sitting down comfortably. So what were the barriers? Well, they weren't just what we could see. There were loads and loads of hidden barriers to implementing this service in the NHS, because it's a completely new service and nothing else at all. So the barriers included, for example, the NHS is in a period of austerity. Budgets are very, very tight indeed. So we're coming in and saying, you need to pay for this service. They didn't want to. So the reorganisation meant that the CCGs, who'd just come into operation when we started the company in 2012, they were just coming into operation, they didn't know what they were doing. They hadn't even got their feet under the table yet. So we were coming in asking to do something new, and they were going, I don't even know what I'm doing with the old yet. So it was very, very difficult climate to start something new. Lots of changes in the NHS in terms of personnel, people being promoted, people leaving, different things going on, people taking on different roles all the time. And also the other priorities like critical care and A&E and things like that. So those priorities took precedent, even though they were aware that this is a big problem. So because of the GPs are being under a lot of pressure, the contract is not satisfactory, so many are retiring. So we're in a big shortage of GPs, so they don't want to take on anything new either. Lack of awareness of the scale of the problem. GPs don't necessarily recognise that this is an unexplained symptom. They call it IBS or fibromyalgia, and then it gets filed under something like arthritis. So there isn't a category in their filing system for MUS. So they're all scattered all over the place. So it's very difficult to do an audit of how many patients in a particular practice suffer MUS. Well, I said that. GPs' indifference, yes. The GPs, until they took over the CCG, really in 2013, they really got the hang of it. They weren't bothered about the cost of anything. They'd refer you for a scan and they had no idea how much it cost. But now they're actually running the CCGs. They're running the budget, so they know exactly how much things cost. So it's quite a different culture now. The GPs as a group are quite traditionalist, and they have their own way of doing things in a particular routine. So it's quite natural that they would be suspicious of anything new coming from somebody who's not a medic. I'm not a medic. The GPs listen to other GPs, but they don't listen to other people. So it was quite difficult to find a way to really access them to be supportive, not being a GP myself. But they are accustomed to referring, like for gym membership and other private private hospitals and so on. They are accustomed to referring privately, but they are known. Those other private enterprises, if you like, are known already to the GPs. We were unknown. So a lot of challenges. If it was easy, there'd be loads of people doing this. You see? There's a lot of challenges. So what were the barriers? How did we overcome these barriers? Well, we had to do all that, climb over them, go around them, go under them, and blow them up. Well, what did we do? We did lots of presentations in GP surgeries. They have an hour for lunch, and usually our presentation would follow the big pharma company doing their presentation on the latest drug that they want to sell to the GPs. And so we'd have like 10 minutes at the end of that to get our message across. So lots of presentations. We did presentations to CCGs, we did presentations to the locality groups that GPs are members of, and we did presentations in the practices, obviously. We gathered feedback. Importantly, we gathered feedback from the GP about how was that form to fill in? How was that referral process? How did that go? A lot of them didn't want to answer us. Occasionally, we got a phone call or we got a note or scribbled on a piece of paper about, do it like this or do it like that. Well, that wasn't very clear. So we gathered some feedback, and also gathered feedback from the patients, obviously, through the participant experience form. We identified the mental health leads, particularly, and we identified somebody who could be a champion, and asked them to write to the GPs to introduce the service. And that helped because they were GPs, and of course they would listen to those GPs. Yeah. And the other important thing we did was we provided the GPs with a narrative so that they could talk to the patient about medically unexplained symptoms, and then they could refer the patient by having some information to tell the patient about where they were referring them to, because they didn't really understand what this service was. So we gave them a narrative that they could just follow. We also offered them a screening tool for inclusion-exclusion criteria, which was just a tick box, which was really simple and quick. And we provided them with online referrals.
Helen, that was fascinating. Really enjoyed your talk. Do you have plans for longer-term study of the effects, the transformative effect? I'm sure you do, but would you like to tell us about them?
Yeah. Well, we're at the moment working with Norwich, University of Norwich. The clinical trials unit there have just adopted us, our team, to do an application to the National Institute for Health Research, HTA, the Health Technology Assessment, which is for an RCT. So if we're successful in achieving that, we will be doing a 3-year study looking at exactly that with a control group with 264 patients, randomised, which is what we need, really. I mean, it's all very well doing these small proof of concept studies and then lots of practice evidence base, but we need a control. So that will support it. Hopefully, the outcomes are good.
Good luck with that.
Thank you.
Can I ask a question? I think one of the things that for me is exciting with this work is that you have a service that somehow starts from the university.
Yes.
And from you as a sort of apart from the therapy hat, you primarily, sort of working at the University of Hertfordshire, you developed a service that is a service that is used in the NHS and used out there. Have there been challenges and difficulties doing that? That's not a common model.
No, and it wasn't easy because we had to go through Dragon's Den at the University of Hertfordshire. We had to go down, up the stairs and down the stairs, and there was a panel, and we had to present our business case. And then they agreed after we did the business plan. First of all, we got money to do the business plan, and then we got money to take it a bit further and do a little bit more in-depth modelling. And they thought it was good enough, and they invested in it. So they are, if you like, a sleeping director of the company. We have to have board meetings with them every so often. But they have been very supportive indeed in promoting, not only promoting it in terms of investing financially in the company to get it off the ground, because you need every startup company needs finances to start with, because you don't just go in and get a contract straight away. You have to work at it, and you need to develop things over time. So they've been very helpful in supporting us through that first 2 years financially. And of course we've got at our disposal, for example, the Twitter account. Every time we tweet something, if it's in their interest, they will double tweet it, they will retweet things and so on. So we've got the sort of social media side of it.
How can we prevent to have them? Like, how can we connect with the body to be able of avoid to have all of these problems?
How can we connect in order to avoid having all these problems?
Prevention.
Yeah, prevention, exactly. Well, I think some of the things I was talking about, we need to take care of ourselves. We need to listen to our bodies. We need to be kind. I mean, all the things I was talking about would be preventative of these sorts of symptoms.
It's like listen to your body, like what's telling you.
I think self-awareness and body awareness are intertwined. You can't have self-awareness without body awareness. You can't have body awareness without self-awareness. They're intertwined. So anything that promotes that, and of course psychotherapy promotes self-awareness. Dance movement psychotherapy promotes self-awareness through body awareness.
We have one more person. Should we stop there?
And then you can ask me on your own, separately.
Just a quick question. You were talking about the connection with the GPs and sort of connecting. I would probably say presenting the service in a way that will complement what it is they're doing. And I suppose I'm wondering how things stand now. Just because my experience is that the conventional sort of NHS tend to see in alternative solutions either a competition or non-effective. So I'm kind of wondering where you're at within this sort of channel of communication.
It's a very, very good question, because the IAPT initially saw us as a threat because we were going to take business from them. But in fact, we're complementary to IAPT. In fact, patients will go to IAPT after they've been to us because they see the point now that, oh, yes, okay, then make that link between bodily symptoms and stress. And maybe the CBT could help now. So it's about making that relationship and talking about what we do in a way that they can see is not a threat, and for the GPs as well, to convince them that to give it a go, to give it a try. And of course, the patient will go back and go, "This was really helpful." And then that's our best advert, really. And I've had GPs find my phone number, which is ex-directory, and phone me up and say, "Oh my God, I'm so glad I haven't got that patient coming back every week. It was awful, I didn't know what to do with him." So yeah, it's about making it clear how we can support them to support us, really. Thank you. Thank you.